Okay, everyone, we're going to move on to the final section of lecture 25, which is about herpes and HIV. Specifically, we're going to talk about HIV epidemiology and public health. So first, let's talk about data that we have on HIV in the United States. I showed you that earlier graph where we had that very large peak in diagnoses and deaths in the late 80s and into the early and mid 90s that then came down as a result of aggressive public health campaigns encouraging people to have safer sex. So we know a lot about HIV now, and we have highly effective treatments that are available. So you would think that our numbers would continue to go even further down than they have been. And that is the case for some subcommunities, but not for all. So as we look at this data here, looking at incidence or new diagnoses of HIV among people in the United States from 2010 to 2015, we can see that in many of these age groups, the virus is indeed decreasing, but young adults aged 25 to 34, we're seeing a significant increase in the numbers of new HIV infections. Not a good sign. We also know that different subpopulations are disproportionately affected. So this is new cases per year. The majority of them are in white men who have sex with men. Close second, black men who have sex with men. Then still men who have sex with men but who identify as Latino or Hispanic. And then black women, black heterosexual men, white women, and then down here we have IV drug users. So certainly because this illness in the United States was first introduced into the subcommunity of men who have sex with men, who primarily have sex with other men who have sex with men rather than with straight women or straight men, speaking in binary categories, right? That's the community in which the prevalence got really high. So now if you are a man who has sex with men, the prevalence in your subcommunity is higher, and therefore your risk, even if you're doing behaviors no different than anyone else, your risk is going to be higher of contracting this illness. Remember, when we talk about different subcommunities of which we are a part, geographic can also be one. So the top 10 cities, right, with the highest rate of new HIV diagnoses, so Baton Rouge, Louisiana, Miami, Florida, New Orleans, right? So these are places where we're seeing lots of new cases. There's lots of people getting infected. On average, as an American, your risk of getting infected is about 1 in 99, right? But if you're in the South and Southeast areas of the United States, your risk is even higher. So we talk about, depending on where you are, the people around you, the people with whom you hang out, and the prevalence in that area is going to determine your risk. So how do we diagnose HIV? I touched on this briefly earlier. So most HIV tests look for antibodies against the virus. So that will indicate that you have been infected. So we can do that from a finger stick or a cheek swab. Those are really quick tests. We can get results in 10 to 15 minutes. They're screening tests, so there can be some false positives. So what I always tell people is if that test comes back positive, it doesn't necessarily mean anything other than the fact that we need to do a more specific test. So if that screening test comes back positive, then we go on and do a confirmatory test, which is going to be more accurate. In the general college population, about half of all the positive screening tests are false positives, depending on that person's particular risk characteristics. So if they're a low risk person, about half of the positives were false positives. So there are other things that can make this test turn positive. The other thing to keep in mind, though, is that if you test too early, it can be a false negative. So remember, we mentioned it can take several weeks after getting infected for your body to make antibodies that will show up on a test. So we talked about during the acute infection phase, when there's a lot of virus and you're very contagious, a screening test will typically often be negative. So we do have some tests that look specifically for the presence of the virus itself, and they'll be positive once the virus replicates to a level where it's detectable, right? So usually within 1 to 2 weeks of getting infected, sometimes even sooner. These tests are a little bit more expensive, however, and so they're not widely used for screening. So if we think that somebody might have very recently been infected with HIV, we need to know that and do this specific test instead of the general screening test. How do you prevent HIV? Well, certainly you could not have sex, right? Or you could be mutually monogamous and you could both be HIV negative at the start, and that will work, right? Both of those things work really well. Condoms will also work really well for HIV prevention. They're not as effective for herpes because they may or may not cover or protect the area of infected skin or tissue. But for HIV, which requires the exchange of body fluids, right? So with your mucous membrane or broken skin. So a condom prevents semen from being released into your partner. So it prevents that release of body fluids. And then the condom is also covering the penis and protecting that urethra from getting infected by the vaginal secretions or anal fluids of the person with whom you're having sex. So condoms are extremely effective at preventing HIV. I will say that again. Condoms are extremely effective at preventing HIV if you use them. The other option that we have is something called pre-exposure prophylaxis. So prophylaxis just means preventing. Pre-exposure means you're going to do this ahead of time to decrease the likelihood that you will get the infection. And so what this is, it's often called PrEP for short, pre-exposure prophylaxis PrEP, is you take a medicine every single day. Right now it's a medicine sold under the brand name Truvada. You take it every single day and you have this antiviral medicine then circulating constantly through your bloodstream. And what we found is that if people follow instructions and they take it as they're supposed to every single day, it is 100% effective in preventing you from getting HIV. This is amazing, right? So there are some people who, for whatever reasons and despite our best intentions and our best efforts, who will not always consistently use a condom. And so this is a great way to help protect them from getting HIV. The other thing that's often talked about as a preventive measure is partner screening, right? So having your partners get tested or testing yourself. So this is excellent and is good practice, but remember, someone could potentially still be infectious and have a negative test result, right? Getting tested doesn't prevent you from getting infected, right? It's just important information that you can kind of use to assess your overall risk. And then finally, treating infected people is another way for us to, from a public health standpoint, decrease new infections of HIV. Because if we're successfully treating someone, then they are not contagious, right? If we are absolutely suppressing their viral load, then they can't infect other people. So what about screening for HIV, right? So what about doing screening tests? So remember, our criteria for an effective screening program are that the infection is common, it's often asymptomatic, it can be dangerous, we have a good test, and we have a good treatment. So how does HIV stand up to these criteria? Well, it's not super common, but it is asymptomatic, it is dangerous, we have a fairly good test, and we have very good treatment. So therefore, all adults are supposed to be offered testing at least once a year. You don't necessarily need a test every year, depending on your behaviors and your risk factors, but all adults should be offered testing. Part of the rationale for this is that even though we know that less than 1 in 100 people usually has HIV, about 20% of the people who have it don't know they have it. So not only are they at risk of developing AIDS down the road, but they are also then likely to infect lots of other people. We're going to offer this to all adults too, because not everybody will disclose their risk factors to their medical provider. So we just kind of want to make it universal so people don't feel like they have to say, well, actually I belong to this marginalized group and so I'm at higher risk. Let's just test everybody, because we want to prevent people dying from this illness. We're also going to test all adolescents who are sexually active and who use injection drugs, all pregnant women, because we want to be able to prevent their infants from getting infected, and then in men who have sex with men, because they have a higher community prevalence, right? So their risk is higher just because of the groups of people with whom they tend to associate, not necessarily anything related to their own individual behaviors. We're going to check at least once a year, or sometimes every 3 to 6 months, depending on behaviors and risk factors. So we talked about HIV in the United States, and we have this problem with a lot of people who aren't diagnosed. We have some subcommunities where incidence is increasing, so young people, people of color, people in the southern regions of the United States. What does HIV look like in the world? This map gives you an idea of how different this illness is in different parts of the world. So the darkest red that you see here, which is the color for most of southern Africa, the prevalence in adults is more than 15%. That means that more than 15% of adults have HIV. That is incredibly high, right? This is a fatal illness. This isn't herpes, right? This is something that can kill you. And so in some countries, in fact, and in some regions, it's as high as 20 or 25%. So there's many interesting things about this. It's also very sad. But one of the reasons why it is so much more prevalent is because in the southern African countries that you see there, the HIV virus got introduced not to a small subgroup or small subcommunity of men having sex with men. It got introduced into kind of the larger subcommunity of men having sex with women and women having sex with men. And so there was just a larger, statistically, a larger number of people than that this virus could infect who kind of identify as people who are sexually active with people of the opposite sex. So we see a very different epidemiologic picture in different countries depending on the types of subcommunities and where this virus kind of got its initial foothold. So this video here, which is in the discussion or the description, is a really important and brief piece about some of the other factors that have nothing to do with biology and everything to do with economics and culture and politics that have a huge influence, and education too, that have huge influences on the rates of HIV in southern African countries. So I'm going to ask you to pause and take a moment and watch that because it's really important. So we still have lots of challenges today. So in the United States, rates are rising in men who have sex with men and African American populations, especially among young adults and people in southern states. And in the world, HIV is still the #1 killer in many countries. The drugs, although highly effective, are expensive and they're not accessible for many people. Condoms also aren't easily available in many places, and in some, even though they might be available, it's not culturally acceptable to use them. And then also, once the prevalence in your area, in your region is very high, then everyone's overall risk of contracting the virus is higher, thus compounding the problem. So in summary, after years of decline, we are seeing a rise again of HIV rates in the United States, more so in certain sub-communities. And when it comes to prevention, however, condoms are highly effective. Also, pre-exposure prophylaxis, or PrEP, is also highly effective for people who are high risk. Remember, they can take a medicine every day. In terms of testing, we have this rapid antibody testing of a finger stick or a cheek swab that is recommended for everyone to be tested at least once, but we have to keep in mind it can take several weeks for that test to turn positive. There are also false positives with that test, so keep that in mind. If that test is positive, we do a confirmatory, more accurate test. We can also test for the presence of the virus itself, but we're going to use that in certain unique situations because it's more expensive. And then in the world, again, this is a huge killer in many countries where drugs are inaccessible, condoms aren't easily available, and cultural practices can increase risk of this disease. All right, so that was actually 25E, and so we'll pick up with our next lecture, lecture 26, talking about our last viral STI, HPV, or human papillomavirus.